Okay, this topic, what we're talking about is an overview of the healthcare continuum. But when you talk about the healthcare continuum, one of the things that you have to recognize is you are a player within that system. You're a player within that continuum. And one of the first things that, in order to talk about the continuum and your role, we have to talk about you, who you are, what you bring to the table. Because the healthcare continuum has an opportunity to either help or hurt you. So, who are you? Well, you are made up of a series of elements or spheres. And spheres is something that's constantly talked about. You have emotional side that you bring to the table, and how you feel about your health, and how you feel about not being healthy. The same thing with spiritual. You have spiritual tools that you bring to the table to help you to stay healthy. And when turned on its head, those same belief systems can cause you to be not in a degree of comfort, not in ease, and can actually create illness for you. You have the cultural aspects, your cultural health belief models, the things that your parents and your grandparents and your great-grandparents brought to the table and offered to you. Look, for example, at what we call a cold. It's a cold. How did we get to the word cold? And with a cold, how do we feel best about treating a cold? We want to do something warm. So those are just examples of some of the cultural things that we bring to the table. And then there's the physical you. The physical you has certain age, certain characteristics, certain abilities, certain disabilities. Those things, a fitness level, all of these aspects have an opportunity to be positively or negatively affected by the healthcare continuum. And then there's the relational side of you. There is family and what family means to you, employment and what employment means to you. If you're the primary breadwinner for your family and you happen to be a concert guitarist, the loss of the function of one hand means a lot more to you than it does somebody that still wants and still needs their hand, but what they do is they drive a vehicle, and there's adaptation available for them. So what are those relational things that you bring to the table that can be effective? After we look at those, we try and put those into some sort of a continuum. Now, I've artificially created a left-right for wellness and illness, ability and debility, and birth and death. These are artificial lines. How long are they? It changes for everybody. Are all of those negative to the left, positive to the right, positive to the left, negative to the right? No, not necessarily. And so all of the tools that you bring to the table cause you to place yourself on one of these continuums. And if I were to ask you, using this red marker, where you are today, are you a little more well or are you a little more ill? This is flu season in Texas. This is flu season in the United States. Things are not going very well with the flu right now. Emergency departments are overwhelmed. Emergency departments within the healthcare continuum. People are taking care of themselves at home. People are taking care of themselves by throwing themselves into the healthcare system in order to receive some assistance. What does that do for you? Does that help you to get well? Does it make you to feel more ill? I went for a flu shot, just to use a personal story. I went for a flu shot a little over a week ago. And when I came out of this clinic where everybody was hacking and coughing and the people that I saw in the waiting room where I was sitting not being healthy at all, bringing their own ability and debility to the table, I came out of there with a flu shot for my wellness, feeling toxic. So sometimes the healthcare facilities are not the supporters of wellness, and you have to look for that wellness being on this end of the continuum from other things that you bring to the table. Same thing with ability debility. Where are you within this? Your knee is hurting a little bit today. It's harder for you to stand up. Maybe you're a little further to the right. Maybe you have chronic disorders that causes you to not even be able to walk. But that doesn't mean that you have debility. You've adapted, you've adjusted, you've accepted what it is that's going on in your life and your body with all of the tools and abilities you bring to the table. So you are very able, whereas somebody else looking at you thinks that you have exceptional debility. That's not true. Now, same thing with birth and death. Some people only live 18 months. Some people live 120, I'll cut it off at 120 years. Where are you within that? You have no idea where you are within that. It could change on the way home, and I certainly hope not. It could change because of some things that you do in your life. The smoking and the drinking and the carousing. It may add to a feeling of wellness, but it certainly shortens the birth-death line. So where are you within this? And what are some of the things that you can do to push death out further, assuming that death is unwelcome? Now, this is a relatively busy slide, but I want you to look at those things on the illness-wellness continuum, or we'll call it ease and dis-ease, if that's what you want. What are those things that push you further over to the illness side? Well, taking into account being in a room of people who cough and hack, people who don't wash their hands and pass diseases on to you, sitting next to some of these people on an airplane, those are things that definitely move you from the wellness side over to the illness side. Stretching, dancing, feeling better about yourself, good spiritual context for yourself, those are things that push you over to the left, towards the wellness end. Accepting your current circumstance, having the right level of relationships, stress management, illness control, high quality of life. Those are things that push you over to the wellness side. And these are things that are to be supported. Those things that push you to the right are things to be avoided, controlled, addressed, dealt with, so that they don't push you to the right. But these are things that go on all the time. You constantly have these items at the bottom that push you to the left, and these items at the top that push you to the right. You live in a constant balance with them. You live in harmony with them, but you try to affect them to move your yoga that pushes you over to the left, even in the presence of inability to move your left foot or that pneumonia. So, moving on, if you talk to people within the healthcare continuum, within the healthcare system, let me use the healthcare system phrase, what are the things that we can all agree upon? Well, they certainly agree that you need a high quality of care and a high quality of life. Some of them may be incapable of teaching you how to have a high quality of life, but they can contribute to a high quality of care. Well, that's the same thing that you want. You want a high quality of care. You want a high quality of life. Now, the high quality of life, you probably have more to do with that than some of the people within the healthcare continuum, within the healthcare system, within the healthcare continuum. But the high quality of care. But the high quality of life, you are a much more active player in that than they are. You learn from them. You take advice from them. But the high quality of care, it's probably time to start demanding from them a higher quality of care. And those are some of the things that we want to talk about. Getting back to your personal end-of-life continuum, at the right end of the life, it's important to remember that every medical study ever conducted has concluded that 100% of all Americans will eventually die. We accept that, we know that. The other statement is there's no getting out of this life alive. It's just the way it is. What do we do during that period of time, and what do we do near the end of that time? And it's unfortunate to say that 18 to 20% of Americans spend their last days in an intensive care unit. And that is not where most people say, years before that, oh, I know what I want to do at the end of life. I want to die in an intensive care unit. This is part of where you start to take control of your quality of life. And you say, this is not where I want to be. I would also make the statement that the hospital, and I've worked in hospitals for years and have worked at and within hospitals and supporting hospitals and inspecting hospitals for years. A hospital is a terrible, terrible place for a sick person. Whatever you can do to get out of a hospital is exactly what it is that you should do. Last year, Medicare spent $55 billion just for doctors and hospital bills in the last 2 months of patients' lives. And that's more than the budget of the Department of Homeland Security or the Department of Education. Again, this is just in the last 2 months of patients' lives. This is something that is not to be desired, not to be the elements of an excellent healthcare system. But how we get there sometimes is because the healthcare system is on autopilot. If you meet the criteria for something that comes next, that's what you do. You do that next. But don't confuse typical care with appropriate care or necessary care or ethical care or correct care or necessary care or any kind of necessary care. Just because it's typical doesn't mean that's the way it needs to be. So let's switch to who are the principal players within healthcare. Well, there's you and your system of advocates. You and your family, you and your advisors, you and your neighbors, you and the people who advise you. And then there's the healthcare system, which is everybody else. Now, the healthcare system attempts and tries to act as your advocate, but they can only advocate with you. They can't advocate in the absence of your participation. They can try, but they'll always come up short of the ideal. So we can look at the physicians, dentists, nurses, social workers, podiatrists as the people. And then there's the facilities themselves, the hospitals, nursing homes, the office practices, hospice, durable medical equipment companies, which, for those of you who are not familiar with them, they're the people who, if you have to go home and breathe oxygen while you're at home, they're the people who provide the oxygen. If you have to go home and you need medical equipment in order to maintain either a new kind of drain that's in your body or IVs in your body or things like that, if it's going to be done at home, that's a durable medical equipment provider. If you need special shoes, that's durable medical equipment. So that's who they are, and then they're frequently unrecognized within the healthcare system. And then there's the insurance companies themselves within the healthcare system. It may be sometimes that insurance companies would like to perceive themselves as not being a player in the healthcare system, but just a company that fulfills a contractual agreement that you make with them. But I think that any rational person knows they are guiding a lot of things that go on within the healthcare system, and more so than maybe some of the other players would like. And they do that based on, you have agreed that this is the plan that you want, therefore this is the plan that they're going to provide. But that affects many decisions and much decision making by many of the players within the system. And the last component that depending on how you describe the healthcare system, I'll pick the regulators. The regulators, having been one, we recognize, we think of ourselves as an advocate for the patient. We can't be. The most we can be is an advocate with the patient. We feel that we're an advocate for the facility itself, but we can't advocate for the facility when they don't advocate for the same thing that we do, which is the patient. And we view ourselves as kind of a neutral entity, but we're not neutral. Even the organization that I worked for used to be called the Healthcare Finance Administration. Finance, money, it's part of the healthcare system. It has to be recognized, and we can live in balance with that. But regulators will frequently fill a void with regulation, and that is not necessarily a good thing, but it is the way the system has evolved over the years. Next, I want to talk about the healthcare system, and this is very brief. If the healthcare system were run like some other industry, or some other industry were run like the healthcare system, if banking were run like healthcare, as it is today, automated teller machine transactions would not take seconds, but perhaps days or longer, or as a result of misplaced or unavailable records. If homes were built like healthcare systems were run, carpenters, electricians, and plumbers would each be working from a different set of blueprints, and there would be very little coordination amongst them. And I realize these are very negative statements about the healthcare system. But this is the way it's evolved, even though they reject it themselves. They don't want this. But it is the way it evolves. And we'll look at this last one here. If airline travel were like healthcare, each pilot would be free to design his or her own pre-flight safety check, or decide not to use one at all. And that's not desirable in healthcare. Healthcare is regulated to where it has to be done, but they also self-recognized that it had to be done. I read an anecdotal comment a few years ago that when air flight first began, there were so many negative outcomes that it was decided that a pre-flight checklist was going to be needed. And when it was first implemented, air crashes reduced by 70%. It's interesting that the healthcare system has looked to the activities within a cockpit as ideal practices within healthcare, and have brought those presenters from the airline industry into the operating suites and into the decision-making process, saying, how do you do this? How do you get so many parts flying in close formation and safely take off and land day in, day out, so many times with so few errors, whereas we in the healthcare system are not so blessed. And those lessons that have been learned are being brought to the system, but here's why. In 2012, 10 years after the Institute of Medicine, an agency of the National Science Foundation, I believe that's where they said, they wrote a report to Err is Human. And that estimated that medical errors cause up to 98,000 deaths in the healthcare system, not hospitals, but the healthcare system per year. And roughly 15% of hospital patients are still being harmed during their stays. Nobody wants this. Nobody within the healthcare system shows up at work today and says, I want to harm somebody. They say, I want to provide the highest level of care possible. And they strive to do that. But what causes this? Well, it's a combination of poor care coordination, different players marching through the system, trying to do the best thing, and a lack of coordination. Roughly 20% of discharged elderly patients return to the hospital within 30 days. This was perceived by the government to be a void, and they threw regulations at it, saying, if you return to the hospital within 30 days, you will be evaluated accordingly as a hospital, and you will be paid accordingly as a hospital. So it's important to know that this is the current circumstance, but this is not desired by the healthcare system. They're not indifferent to this. Okay, So I threw up probably the wrong choice of words in the flu season, but I placed up on the screen here just a circle. And let's presume for a second you have a cough or a flu. You didn't get that flu shot. You were in with a group of infected people. You were even sitting in that clinic that I was at, and for some reason the flu shot didn't take. But you're in this primary care physician's office. You see the physician, the nurse practitioner, or the physician assistant, and they say, you know what, I think you're sick. I think you have either flu or pneumonia. And so we're going to send you over to the internist and have them, or the pulmonologist, we're going to have them check you out, because in your continuum, you are moving towards the illness end. And the question is, how ill? Can we just treat you with antibiotics? We're going to send you over to somebody to take a look at you. So you go over and you see that person, and they say, oh, you are definitely sick. So we're going to admit you to the hospital, but because of insurance reimbursement, we're no longer going to follow you. All of that information that you had here in your primary care physician's office, some of it will be faxed over to this new person who's going to manage you, which is the hospitalist. Now you notice I didn't even run you through the emergency department and all of the people involved there. But the hospitalist is going to manage you. So you're in the hospital, and now you're in the end of day 1, day 2, and the hospitalist says, you know, your lungs are bad enough through your age or debility or your past history of smoking or how bad it is that it's going for you right now. We're going to have the pulmonologist see you. So now the pulmonologist comes and sees you and says, you know what, your lungs are pretty bad. This flu is really hitting you bad. It's developed a little bit into pneumonia. You've got some bad stuff going on. So we're going to put you now in the intensive care unit. In the intensive care unit, now you're going to be managed by the intensivist. The intensivist is going to be dealing with you in the ICU, medicines, treatments. All these therapists are going to come in. Everybody's working with you to get you unsick, or as unsick as possible. And they succeed. So the intensivist finally gets you out of the ICU, and now you're going to be seen by the hospitalist again. Well, you've still got those little pockets of things in your lungs, and well, what's really going on? We've still got questions. So the radiologist is going to take a look at it. Maybe they or the pulmonologist are going to pull some specimens out of your lungs and send it to the pathologist. And yeah, you're infected by some stuff that's pretty resistant. We're going to give you a lot of medications, but we really want to look at the continuing care of you, because as we're giving you these antibiotics, it's really going to knock out a little bit of your immune system. This infection control preventionist, which, if I may say so, is one of the more important people in the hospital, now is consulting on your case also, or visiting you periodically, and watching everybody's practice around you to make sure that you are not reinfected, that the antibiotics are taking care of everything, that everybody's washing their hands around you. And, oh, here comes the discharge planner. The discharge planner now wants to move you out of the hospital, which is an excellent idea. Because as I said, the hospital is a terrible place for a sick person. As soon as you can survive outside the hospital, you really need to get out of the hospital. And because of all the things that we've heard in our favorite medical journals, Prevention Magazine and Home Shopping Network and all of the other places, we've all learned, and in this case accurately, that you want to get out of the hospital as soon as you can. So this discharge planner tries to figure out where could this person survive. And they've got a lot of choices. They've got nursing homes, they've got your home, you've got step-down units, you've got skilled nursing, you've got all kinds of places. But it's decided that you can go back home, but you're going to need assistance of more than just you and your family. So they bring in home health. Because you had this terrible lung condition, you're now going to need some oxygen at home, and you're going to need some special therapies. So you're sent home with durable medical equipment, some oxygen and some breathing treatments. And you're going to be managed in an outpatient setting by that same pulmonologist that you saw in the hospital, or somebody in their practice, or somebody in your insurance plan. So this pulmonologist is going to help you with the therapist get well enough that now you're on the road to recovery. Now you're told, okay, you don't need the specialist anymore, you don't need the therapist anymore. We send the durable medical equipment back. We turn off the home health care, and you're back in the care of your primary care physician. And this is not the ideal continuum of care, but it is what goes on when your continuum of care really is just, you see your primary care physician and you get stuck in the hospital periodically. It's really not where we want to go. Let's look back at this personal continuum again. And now maybe we can see that the illness-wellness continuum is something that you have to manage all the time. As I was talking about this previous pathway, very little in here did I say, what did you do? What could you have done to prevent this, assist this, to move yourself faster over to this side? What are some of the things that you could have done? I'm going to take a break for just a minute, and anyway, we're going to stop for just a minute, and then we have a technical thing that we have to take care of, and we'll be right back.